All right, we're already on live, and then we're on live YouTube. So we're going to start in a minute. Okay, good afternoon, everyone. My name is Tan here. I'm the ophthalmologist from Hospital Temerloh. Welcome to another surgical webinar organized by Malaysian Young Ophthalmology Special Interest Group. We are actually part of our the MSO Malaysia Ophthalmologists of Malaysia Special of MSO Group from Malaysia. So today our topic for the surgical webinar is cornea, and we are fortunate to invite one local cornea consultant and the other one from Hong Kong, Dr. Liew and Dr. Kam. So put your hand together for Dr. Liew and Dr. Kam. So a bit housekeeping message before we start. I'll start my introduction for Dr. Liew and Dr. Kam. So all the participants will be automatically muted, and you are welcome to leave any Q&A, but we are going to answer it at the end of the session. So without further ado, I would like to introduce Dr. Liew, Dr. Liew On Heong. Dr. Liew On Heong is currently the consultant ophthalmologist and cornea consultant in Kota Kinabalu Queen Elizabeth Hospital. And Dr. Liew obtained his medical degree in 2006. He obtained Master of Medicine in Ophthalmology in 2015. He further in the cornea subspecialty training under Ministry of Health and obtained his fellowship in Chinese University of Hong Kong in early 2020. So today he will be giving us a topic, the use of cyanoacrylate glue in corneal perforation. So our second speaker, Dr. Kam Ka Wai. Dr. Kam Ka Wai is our consultant ophthalmologist and cornea consultant in Prince of Wales Hospital and Alice Hall-Muirling Nethersole Hospital from Hong Kong. So he graduated as MBBS from University of Hong Kong. He obtained his residency and fellowship in cornea and external ocular disease under Chinese University of Hong Kong. He's currently the associate consultant of the Department of Visual Sciences, Prince of Wales Hospital, Alice Hall-Muirling Nethersole Hospital in Hong Kong. He also obtained several fellowships, member of Royal College of Surgeons from Edinburgh, beside the fellowship of College of Ophthalmologists of Hong Kong. He also obtained fellowship of Royal College of Physicians and Surgeons of Glasgow from 2019. He will be enlightening us with the topic of usage of amniotic membrane in acute Stevens-Johnson syndrome. Both topics is actually very relevant to us as ophthalmologists in day-to-day practice. Especially in Malaysia, we have a lot of workers in the district, and then unfortunately the rate of corneal ulcer is very high. And on and off, you see patients with acute Stevens-Johnson syndrome also. One glance look at it, it is very terrifying because it involves all the mucous membrane, including the conjunctiva. And unfortunately, the eye cannot close and it got infected. And then we go out of hand most of the time. So we would like to start off our webinar today by inviting Dr. Liew. Dr. Liew will be enlightening us with the usage of cyanoacrylate glue in corneal perforation. So I give the floor to Dr. Liew.
Okay, thank you, Dr. Tan, for the kind introduction. It's my honor to be invited in this Malaysia Young Ophthalmologist Special Interest Group to give this talk. Okay, I start to share my screen. Okay, can you all see my screen?
Yes, yes.
Okay, okay. So the topic I would like to share today is perforated corneal ulcer. And what would you do if there is no tectonic corneal transplant available during this pandemic period? And there is no financial interest or any conflict of interest in this presentation. Okay, so the cause of corneal ulcer perforation is can be due to many causes, mainly bacterial keratitis, fungal keratitis, acanthamoebic or viral keratitis, PUK in the infective causes or autoimmune-related disease, ocular surface disease, trauma, chemical injury, or Stevens-Johnson syndrome. The patient may be experience of sudden deterioration of the vision in the case of acute perforation, or maybe have acute eye pain or excessive tearing. Clinical examination, you may see desmatocele, a shallowish AC or flat AC, or uveal prolapse at the perforation site, and see the test may be positive. It could be negative in the case of the flat AC and no more aqueous fluid to be leaked. Prevention is always better than cure. When you see the early corneal melting, then you should start to treat the patient very intensively. Topical antibiotic prophylaxis is very important to prevent secondary infection. Frequent lubricant and with bandage contact lens is important to improve and help in epithelialization. Punctal occlusion sometimes may be used to maintain and sustain the moisturization of the corneal surface. In some cases, plastography is warranted if there is no improvement in the case. Anti-collagenase medications such as doxycycline or tetracycline may improve the corneal healing and prevent further corneal meltdown. And vitamin C is very important, essential cofactor in the corneal wound healing. However, there's no solid evidence that proves that its efficacy. Systemic steroid and immunosuppressive agent should be used in the autoimmune-related corneal melting. In corneal melting in the infectious keratitis, work out the right diagnosis is very important because different causative agent has different different kind of eye drop to apply. Systemic antibiotic is always warranted in the infective keratitis, especially in the perforated case and also with the limber involvement or scleritis. Systemic antifungal is important in the fungal keratitis. However, some cases with the liver dysfunction, then the systemic antifungal may not be contraindicated. Antiviral for necrotizing stromal keratitis is definitely yes, and we have to monitor the renal function in the case of started antiviral. And same again, anticollagenase medication and vitamin C, it could prevent further corneal meltdown and also improve the corneal healing. Unfortunate case could perforated, and then eventually we have to do the patch graft or tectonic peak penetrating keratoplasty. Look back at the corneal transplant in Malaysia over the years. Mostly the corneal transplant was done with the imported cornea, mostly from the USA, and second come with by Sri Lanka. The local donation rate still very low over the years, even until today. So in the case of acute perforation, and you have no corneal graft, and don't give up in such case. First, you need to seal the perforation. I did some literature search on Medscape, and it shows that there are many options for the sealing of perforated cornea. So I simplify it into the two options. One is the material and the other one is sealant. The material may be used is a plastic disc, bandage contact lens, amniotic membrane, autologous tenon patch, smile-derived lenticule, conjunctiva flap, autologous corneal patch graft, autologous lamellar scleral patch graft, or pericardium graft. The sealant used is cyanoacrylate glue, fibrin glue, or polyethylene glycol sealant. Usually the plastic and bandage contact lens go with the cyanoacrylate glue. The rest of the tissue graft, patch graft, is go with the fibrin glue. And sometimes, very rare occasion, we use polyethylene glycol, but it's only in the small perforation. And tarsography may be done to stabilize the sealing of the cornea. Cyanoacrylate glue is the earliest and easiest, most readily available technique that we use for the corneal perforation. It was published in 1969 that the cyanoacrylate glue was used in penetrating wound of the cornea and sclera, but the article was in Russian, which is about 50 years back. So how it works? Cyanoacrylate glue is actually a monomer of N-butyric butyl cyanoacrylate. This monomer is in liquid form. When in contact with the water, it can polymerize immediately into a solid layer of glue. So in short, cyanoacrylate can prevent further corneal meltdown, prevent the collagenous production from the tissue, from the necrotic tissue, and also it has the significant bacteriostatic activity against the gram-positive organism. However, some infiltrate in the infective cases still can worsen even after gluing. The cyanoacrylate glue also have its side effect. So direct contact and may damage the corneal endothelium and lens. So the gluing technique is pretty simple. What you need is have some topical anesthesia and disposable dressing set, povidone 10% to clean up the eye, and speculum for you to open up the eyelid, with normal saline or BSS to rinse the fornix and clean up the ocular surface, and then use the eye spear to dry up the perforation site, and then to deliver the cyanoacrylate glue with the eye spear. And then at the end, put a bandage contact lens on top of the gluing site. So this is my setting, pretty simple. With the dressing set, I put 2 drops of cyanoacrylate glue on the plastic sheet. I don't have spontac at that point, so I use the puncture dilator. I use the blunt end, the handle there, to deliver the glue. It's similar to the spontac. I put it in the picture illustration. First, you use the tip of the spontac to tap on the glue, and then you will get a very thick layer of glue on your spontac. It will not dry up immediately. Don't worry, you can take your time to do it, because without the presence of water, the monomer still remain as a monomer. It will not turn into solid polymer. So you tap it again on the other side of the plastic sheet, so you thin out the layer of the glue over your spontac. And then you bring it to the cornea, you dry the corneal surface, and then you tap it on the cornea. Once you tap it on the cornea, you have to remove your spontac immediately, because when the glue in contact with the cornea, there is a little amount of fluid. It will initiate the polymerization and it will turn into solid very quickly. So this is an example of my gluing. This patient has a pseudomonas corneal ulcer with the inferior perforation over the right side from this picture. So I trim off the loose stromal, and then I dry up the surface, and then I dry up the surface with the cotton bud before I do the glue, and then I deliver the glue with my puncture dilator or spontac, and then we tap on the surface and remove quickly. You can repeat the same procedure again if you want to cover more area. So this one I did twice because I couldn't cover up the whole thinning area. So the outcome is pretty good. There are two studies that published recently, one in 2019 from Yin. It stated that 46% of the patients with corneal thinning or perforation still doing well without surgical intervention after 3 months. And the second publication from Antros in 2020, 52 patients with 53 eyes were studied. 22% of them have complete resolution after gluing and without surgical intervention. This is one of my cases, a severe PUK not responsive to steroid treatment, systemic steroid treatment, have a severe thinning over the 10 o'clock periphery region. And I did the glue for him to prevent perforation, because usually this kind of case, it will perforate after another 1 or 2 weeks. And this is after the longer follow-up. The patient was also started on a second-line immunosuppressive, and it's completely epithelialized, and you can see that the thinning area actually conjunctivalized and no more obvious thinning was seen. This is the CEDAR test, and also the first instance show no epidural defect. This is another patient with a necrotizing stromal keratitis. Unfortunate for him, he had a perforation during the follow-up, and I did the glue for him. Even until today, he's still on the glue. We don't have any cornea right now. Even the import one we couldn't get through because of the pandemic period now. We don't have any flight and don't have any cornea to reach Sabah at this moment. So I will keep the glue until I got cornea. So in summary, corneal perforation can be sealed with various methods, and most readily available material and the simplest method is using cyanoacrylate glue. Corneal patching with the cyanoacrylate glue is a temporary procedure only. It's for you to buy time for secondary healing, to allow inflammation to settle down, to allow infection to be treated, and for surgery to be elective when integrity of the group restored.
Okay, thank you, Dr. Liew. Dr. Liew, I think the line has some problem, but I think this is his last slide. Thank you, Dr. Liew. Dr. Liew, such a wonderful and simple but yet important topic. We know what to do next time when we have corneal perforation. We do have some questions flowing in, but we're going to reserve it at the end of the presentation. So I would like to invite Dr. Kam for the next presentation on the usage of amniotic membrane in acute Stevens-Johnson syndrome. We welcome Dr. Kam.
Well, thank you very much, Dr. Tan, for your kind introduction. Hi, everyone. I'm Kam. I'm going to share my screen with you. I think Liew just froze and exited.
Yeah.
Oh, he's back in now.
Yeah.
Okay. So, good afternoon, everyone. Thank you very much for inviting me to talk today. And it's my great honor, and I'm very happy to share with you our experience with using amniotic membrane in treating acute Stevens-Johnson syndrome in our hospital. I'd like to thank Dr. Tan for moderating this session, and also Dr. Liew for also inviting me, giving me this opportunity. I work in 2 hospitals in Hong Kong, and they are in the northeast part of Hong Kong. So we are talking about a catchment population about maybe 1 million people in that area. So Stevens-Johnson syndrome, as you said, it's a very rare condition. It's also a very devastating systemic illness. Many people in the past may not survive the acute period, but now with the improvement in ICU care, many of these patients can survive. But the thing is, they have to live with a chronic morbidity. And in terms of the ophthalmic morbidity, I'm sure you have come across patients with very bad cornea, very bad conjunctiva, scar everywhere on the ocular surface. And these patients are living in pain every day because their eyes are very dry and their vision is very poor. In 2016, there is a very nice review published by all the experts in this field on how we can perform or provide management for patients with acute and chronic ophthalmic involvement in SJS or TEN patients. And as you can see here, they suggested amniotic membrane transplant if you see their epithelial defect or pseudomembrane formation. And in terms of how we grade the severity, this is more useful for chronic sequelae. 1/3 of patients with Stevens-Johnson syndrome may end up having these chronic ophthalmic sequelae. This is the score provided by Dr. Sottosano. They looked at 6 parameters, conjunctivalization, neovascularization, etc., and grade them from 0, which is none, mild, moderate, and severe. This is important. Why? Because many of the studies in the coming slides use the score that is just described. Next, I'm trying to convince you the benefits of human amniotic membrane in the literature. Human amniotic membrane has multiple functions. First of all, it acts as a physical barrier between the denuded mucosal surface and the external world. It also contains nutrients, the growth factors, and also it inhibits inflammation in the tissue. It also provides a scaffold for the epithelial cells to grow across, and thus all of these factors help wound healing and regeneration of the epithelium. This is the study by Dr. Darren Gregory, who works in Colorado. And this is his series of 10 patients with SJS or TEN. You can see that these patients have a damage score from 0 to about 11. This is during the acute stage. And these patients, after putting amniotic membrane, they achieve pretty good vision of about 20/20. At a similar period in New York, Dr. Maya Sharma's, they performed another, they looked at their own experience in 8 patients who are relatively younger, like they're at age 5 years old, 10 years old, 2 years old. And among these patients, they have different variety of putting how they apply the amniotic membrane, but nonetheless, many of them can achieve good visual outcome at the final follow-up. This led to another study, which is the retrospective case control study. They tried to compare those who have had early AMT versus those without AMT at all. And in this study, they look at those with moderate to severe SJS, and they see that in the 1 to 3 month period, which is the intermediate period, those with early AMT seem to fare better in terms of their visual outcome when compared to those SJS without AMT. The same trend can be observed in the longer run. However, the p-value became insignificant because of the dropout from the study. Later on in 2016 ophthalmology, Dr. Sharma from AIMS, Delhi, published a randomized control trial, which is a prospective study that looked at the effect of amniotic membrane transplant in acute ocular Stevens-Johnson syndrome. In this particular study, they recruited 50 patients, 50 eyes, and they looked at the functional as well as the anatomical outcome. As you can see from the table on the right-hand side, you can see that the one with AMT versus the one with medical therapy group, you can see that the patients who received amniotic membrane did better in terms of the visual outcome, the tear film breakup time, the Schirmer test, and in terms of anatomical complications, fewer patients would have corneal haze, corneal vascularization, and also misdirected lashes. So this study conclusively concluded that amniotic membrane transplant is a useful adjuvant in improving both the functional and structural outcome in acute SJS. The study that, subsequently there are studies that look at how we can apply these amniotic membrane much more conveniently in the ward or in the ICU setting. On the left-hand side, you see the stitches method, where people use a self-made symblepharon ring, put the amniotic membrane on the eyelid, put the ring in, and then stitch the amniotic membrane on the eyelid itself, and then put the lower part of the ring into the lower fornix, and then finally end the procedure by putting more stitches to the lower part of the eyelid. Dr. Schambach in 2019 published another method which used a cyanoacrylate glue, which is just now mentioned by Liew. Instead of using suture, they use glue to fix the amniotic membrane onto the upper eyelid and the lower eyelid. In the summary of all the studies that I've presented, you can see that how the evidence is suggesting amniotic membrane does decrease the risk of ocular morbidity in the long run in patients with SJS. It is twofold, both structurally and also functionally, there is improvement. However, it's not without limitation. First of all, amniotic membrane, although it's translucent, after you applied it onto the ocular surface, it makes examination much more difficult because you cannot put fluorescein stain on, and it's more difficult for you to examine the integrity of the cornea or the anterior chamber, or to monitor the size of the epithelial defect. Furthermore, amniotic membrane can dissolve with time or become dislodged, and this may require a repeated procedure. And thirdly, amniotic membrane comes from another human being, another donor. Even though we screen out infection in the donor, there's still a possibility of microbial infection because of all the processing involved. And in the literature, there were 2 cases of microbial infections reported at about 3 to 4 months after the procedure. Personally, I've been using AM since 2015 or even earlier, and I've not yet encountered an early infection after applying an amniotic membrane. On the right-hand side in the table, what I want to highlight to you is that amniotic membrane, it's not a magic bullet, okay? So even if you apply amniotic membrane in patients with acute SJS, many of these patients in the long run still suffer from a series of ocular surface complications. For example, 80% of them would have MGD, which is very, very common. About half of them would have lash problems. Half of them would have scars in the tarsal conjunctiva. And about 60% of them would have different degrees of dry eyes. So you have to tell your patients before you put amniotic membrane on that this procedure does not cure your disease entirely. It may help you see better, it may help you have less dry eye symptoms, but it does not cure every symptom in the long run. So currently in our hospital, just now you look at the Sono score, which is quite complicated and it's more suited for chronic sequelae. Nowadays, we based on this classification when we teach our residents when to alert the cornea team for an early assessment or amniotic membrane transplant. So this is taken from Dr. Gregory, and whenever there is a corneal defect, or when there is a defect on the lid margin that is occupying more than 1/3 of the eyelid, or when there is a 1 cm conjunctival defect, either on the bulbar conjunctiva or palpebral conjunctiva, then we'll consider putting on an amniotic membrane, usually within the first 2 weeks. In the 2019 study by Dr. Scheinbeck, they used a very similar approach. They use amniotic membrane in patients with defects with or without membranes, as in here, grade 2 and grade 3. The difference being that they have Procara in the US, whereas we do not have a Procara, which is a contact lens mounted with amniotic membrane. So they use this device when there is no pseudomembrane. When there are membranes on the surface, they would use a conventional amniotic membrane. So a few take-home messages. For the first part is that amniotic membrane has anti-inflammatory, anti-fibrotic effect, and it helps reepithelialization of the cornea. Amniotic membrane in the acute phase, it improves the structural and functional outcome. However, despite the use of amniotic membrane, there's still a significant number of patients who will suffer from chronic ocular surface complications such as dry eye and meibomian gland dysfunction. Early amniotic membrane can be considered in acute SJS in the presence of either epithelial defect of the ocular surface or the eyelid margin, or the presence of pseudomembrane. Next part, I'm trying to show you our experience. So my thanks goes to Dr. Linda Huang, who was our scientific officer at the skin bank of our hospital. So she helped tremendously in the preparation and annual amniotic membrane harvesting in our hospital. I also like to thank the labor suite and also our Department of Obstetrics, because each year they help us recruit a healthy mother who was very kind and who's willing to donate the placenta after delivering her baby. The prerequisite for this healthy donor is a hepatitis B, C, and HIV negative mother who's going to go through an elective cesarean delivery. We're trying to avoid vaginal delivery because we are trying to avoid the birth canal, and we'll take an informed consent. So after delivery of the baby, the obstetrician will take away the placenta, put it in a sterile tray. We'll then take a surface swab to send for bacterial and fungal culture. We'll then peel away the amniotic membrane like this, put a suture on the outer surface with the smir silk, and then we'll put this amniotic membrane here on into a washing buffer. We'll then transfer the amniotic membrane to our skin bank, and we'll work in a cabinet like this. We'll scrub up, we'll have sterile gloves. We'll pour the amniotic membrane into a sterile tray, and then we'll wash the amniotic membrane several times with this washing buffer, which contains penicillin, streptomycin, neomycin, and also amphotericin B as an antifungal. We'll then move on to clean and cut the amniotic membrane according to the sizes that we designed. You can look at the grid here, and there's nitrocellulose paper here for us to mount the amniotic membrane. This is what the membrane looks like after a few wash. It's completely white. The next, I'm trying to show you a video of how we prepare the amniotic membrane in the skin bank. You can see that the membrane appears a little bit pink still, and we're trying to use wet gauze to remove the chorion on the inner surface of the membrane. Now you see that the membrane is not completely translucent. There is still some area of opacity. We're trying to rub it off from the surface. So be very gentle because the membrane is very fragile, and we wet it very frequently to avoid tearing the membrane. If we keep tearing the membrane, then we may not be able to utilize the entire membrane. Usually one placenta is adequate for an entire year of amniotic membrane supply, and one placenta can be divided into 50 tubes of amniotic membrane of different sizes. So lastly, I want to show you the presence of this suture. We put this suture in the labor suite. You can see this is the side of the knot. It indicates the outer surface. And this is the inner surface, which is connected to the chorion. And we're trying to rub away the chorion on the inner surface. So after cleaning the amniotic membrane, we cut them like this into different sizes. The small one is designed to cover just the cornea, whereas the large one will cover the upper lid, the upper fornix, the lower lid, and the lower fornix. When we go to the bedside, we apply the amniotic membrane. We usually will need to check the size, the diameter of the symblepharon ring. So we palpate for the fornixes and then do some math, and then we'll calculate the circumference required for the ring. We usually make several rings, and then we fit it before we use it on the patient. In Asian eyes, we find it a little bit harder because sometimes the eyes are pretty small, and the fornixes may be a little bit difficult for you to put in the ring. So preparing several sizes is a smart idea. We use the 21 gauge butterfly tubing to make the ring. So we don't use 23 gauge or 25 gauge because those rings, the lumen is too small for you to put the tubing into the lumen itself like this. And this is the equipment that we usually use. We use a caliper to measure the circumference. We have the 21 gauge butterfly, we have forceps, and also a field scissors. So next, I'm going to show you several real patients that we encountered in the last 2-3 years. So this lady is a 33-year-old Indonesian domestic helper. So she developed a skin rash and fever in December 2 years ago. And her eyes had both pseudomembrane and bilateral corneal defect, as well as conjunctival defect. So we decided to perform amniotic membrane to both eyes and put symblepharon ring into both eyes. At that time, I'm still using the original symblepharon ring that our hospital provides. It cost about $100 each, and it's single use, so it's quite expensive. But nonetheless, this is what she looked like 1 week after the amniotic membrane. Her corneal defect has healed, her conjunctival defect has healed, and the amniotic membrane looks pretty thin on the ocular surface, and her vision was 20/60 and 20/80. This is what she looked like at 3 weeks with vision of 20/40. There are significant punctate epithelial erosions in both eyes, and she started to have meibomian gland dysfunction. This is what she looked like in May this year, about 16 months post-op, with a vision of 20/20, deep fornixes, not injected eye, and with a stable precorneal tear film. This is what she looked like in the left eye with the vision of 20/20. You can see that she had some superior tarsal conjunctival scarring, but otherwise, her eye looks pretty healthy. We tried, we then started trying the self-made symblepharon ring. And in the beginning, we used sutures to fix it onto the amniotic membrane. The good thing about this technique is that it helps stabilize the amniotic membrane and the relation, well, stabilize the relation between the ring and the amniotic membrane. But the hard thing is when you put these sutures onto the ring, you have to pass through just the amniotic membrane, but not the cellulose paper in the back. So sometimes it takes some practice, and usually it takes about 20 minutes for you to make one ring, 15 to 20 minutes, but it can be done. On the left-hand side, this is done by our then first-year resident, Sophia, on a piece of plastic sheet as a practice. So Miss C is a 58-year-old lady with Steven Johnson after taking levofloxacin. She had right eye disease much more severe than the left eye, mainly right eye's corneal defect and pseudomembrane. Amniotic membrane was, with the ring, was applied twice to her right eye because the first one dissolved after 2 weeks. I'm sorry that I don't have the post-op photo with me today, but at her last follow-up this year in July, she's seen 20/30 in both eyes. The slit lamp examination was essentially normal, except for the shortened meibomian glands. Again, MGD, it's very common after acute SJS. The next patient is 44-year-old man, Mr. F. He's very unfortunate. He had a metastatic lung cancer, which metastasized to his brain. And he was treated with phenytoin for the seizure. And after taking phenytoin, he developed Stevens-Johnson syndrome. So he was initially managed in another hospital and was transferred to us for eye assessment. And this patient had a mainly lid margin involvement and also bulbar conjunctival defect. He had no corneal defect, and therefore his vision was pretty good. But according to the Dr. Gregory's classification, this is already considered as a pretty severe ocular SJS. So we decided to proceed with bilateral amniotic membrane ring. This time we had deliberately left a very long drape on the eyelid skin and see whether this will be a good idea. And it turned out to be no, okay? We were informed by the ward nurse on the same afternoon, that the patient may have rubbed his eye and the amniotic membrane became dislodged. As you can see from the lower photo here, the amniotic membrane was being pulled out of the inferior fornix. So we decided to take a new piece of amniotic membrane, clean the eye, and then put back another piece of amniotic membrane to the left eye. And from this particular patient onward, we learned that for every patient who had an amniotic membrane ring like this, because they're not seeing very well, so we have to give them an eye shield to try to protect themselves from rubbing their eyes and protect themselves, their eyes from touching the environment when they are resting. This is 2 weeks after the amniotic membrane was put in. This is the right eye. All the lid margin defect has healed. And this is left eye. You can see that from the slit lamp examination, the amniotic membrane is not really covering the entire cornea. So it has shifted from under the ring to the temporal side. So because it has already lost its function, we decided to remove the ring and the amniotic membrane, and he's left with the residual epithelial defect in the supranasal cornea. At that time, his general condition was deteriorating, and they are not very keen to go for a second amniotic membrane transplant. So we put a bandage contact lens on, and the defect healed conservatively with topical antibiotic and lubricants. Next patient is a 57-year-old lady with bilateral corneal defect, very poor vision, bilateral upper lid margin and lower lid margin involvement. Amniotic membrane rings were put in on the next day. So this time, given the experience with the long drapes, we decided to try something new. So this time we put sutures onto the skin, like what we saw or what we read in the literature. And we thought it would be a good idea until the patient set up, and then you can see the amniotic membrane starts draping over the sutured area. Well, even though this looks uncomfortable, she does improve after 2 weeks of amniotic membrane with a vision of 20/40 in the right side, 20/60 in the left side. And this is marked improvement compared to the visual acuity upon presentation. This is what she looked like at about 3 months after the amniotic membrane. And you can see that most of the conjunctiva is white, except for the superior conjunctiva. And the same is observed in the left eye, where there's a patch of redness in the superior conjunctiva with punctate epithelial erosions. So she was diagnosed with SLK. She had no prior diagnosis of SLK before, so we don't know whether this existed before the onset or after, or developed after the onset of SJS. The last patient is Miss L, who is a 61-year-old Chinese lady. She had a very complicated medical history. She had neuromyelitis optica, and she was put on immunosuppression. Her left eye had history of optic neuritis before, left with a pale disc, and the left eye vision was poor. Upon presentation, there was multiple corneal defect on the left side, a small defect in the right side, and at that time she refused procedure to the right eye and only agreed to amniotic membrane transplant to the left eye. So this time we did not use suture. We tried the glue method, which looks pretty neat and easy, and we can avoid injecting local anesthesia into the eyelid. And this is what she looked like immediately after the surgery. We do observe these patients very frequently after the procedure because we know that they are not staying in the eye ward. They're mostly staying in the medical, ICU, or even oncology ward. So the nurses there may not be familiar with the management or care of the amniotic membrane. However, she did have a very stormy post-op course after she was discharged. During the same period of time, she developed a new lesion on MRI in her inland mole disease, and the oral steroid was stepped up from 10 milligram to 20 milligram every day. And then we noted a recurrence of the left eye corneal epithelial defect and subsequently turned into a desmetoscele. She was then treated with a tectonic corneal transplant, and the transplant did not heal very well, and which eventually required a temporary tarsorrhaphy, and it took about 2 months for the defect to heal completely. So a summary slide for all the 5 patients that I just presented. All of them had severe ocular SJS according to Gregory's classification. We put the membrane within 2 weeks. Some of them had both eyes, some of them had unilateral. And the vision, all of them except for the last lady had vision outcome of more than 20/40. And right now we have about an average follow-up period of 9 to 10 months. So a few pearls for AMT starters. If you're thinking about using amniotic membrane for your Stevens-Johnson patient, there are a few pearls. When you're taking the informed consent, you should have set the expectations right, okay? Which means that after putting on the amniotic membrane, the patient should expect a drop in vision, especially those without a corneal defect. However, you can tell the patient that the vision will eventually climb up as the defect starts to heal. Secondly, as I said in the beginning, there will be dry eye and MGD after amniotic membrane. So be prepared that this procedure will not cure everything and will not reverse the disease process. You can try a few rings and onto the patient's eye before you pick the final one. I think Asian eyes sometimes are smaller and it's harder for us to fit. I usually prepare 3 sizes and I'll fit all of them before picking the final size. Instruction to patient is very important not to rub their eyes, and you can provide an eye shield to protect the membrane. And last but not least, nursing care is very important. I usually use Nethersole ointment to keep the membrane moist every day, and instead of prescribing a bunch of eye medication for the nurses to handle, because most of the time these patients are not staying in the eye ward, they're in the ICU or medical wards. And I think attendance really matters. Try to attend to your patients every day to see how they are doing. So a few slides more and then I'll end my talk. I think for surface patients, all you need sometimes is just a little bit of tender loving care. And this patient who has pemphigus, all you need is a Nethersole ointment, some Q-tips, some normal saline, and some of your time to rub away those lesions. Because they're staying in the medical wards, the medical doctors are too busy dealing with the rest of their medical conditions, and they often neglected the eye condition, and they leave the eye conditions to our ophthalmologist. But sometimes there are conditions that are simply beyond the realm of just amniotic membrane. This is my first ever private patient who was transferred from another city, and she was attacked by her husband with hot oil and chemical, and resulting in very bad injuries to both eyes and also to the eyelid as well. So in such situation, amniotic membrane cannot help completely treat the condition. You will need the help from plastic surgeons and oculoplastic surgeons. So lastly, I'd like to acknowledge once again the Malaysian Society of Ophthalmology, the Malaysian YO Special Interest Group, Dr. Tang, Dr. Liew, for giving me this opportunity, my colleagues in Prince of Wales Hospital, our patients, our skin bank, our Ops and Gynae, our eye bank, and my friends and seniors, teachers from around the world. So this is a photo taken when Liew was with us in Hong Kong, and in the center, that was my boss. And these are my friends from around the world who work tirelessly, effortlessly on ocular surface patients. So thank you very much for your kind attention.
Thank you, Dr. Kam.
Excellent presentation, Dr. Kam.
Excellent presentation, very comprehensive. I think if all the participants follow this presentation, so the amniotic membrane is not so strange to us. It's not like a stranger to us anymore. To see, to prepare the amniotic membrane, yes, this is a cooperation between the ONG team and also the pathology team. So, hopefully after this presentation, all the young ophthalmologists will have a better understanding, a better guidance regarding AMT, and he has another option in treating acute SJS. So we'll thank you again. Thanks again, Dr. Kam and Dr. Liew. So we'll quickly go to our Q&A session. So the first two questions were directed to Dr. Liew. I'm sure this question will pop up because we were told, we were taught to use this while gluing. This we got it from the butterfly cover, the butterfly the needles cover, as thin as possible. We punch it and then we clean it, and after that we apply the glue on top of it and reverse it on the patient's cornea. So what do you have to say about these two questions, Dr. Liew? Is this plastic disc always necessary?
Okay, so actually, it's not to say not right if you're not using the disc, but for me, if the perforation is less than 2 mm or less, I can just glue it without the disc. But for the perforation more than 3 mm and above, I think using the disc would be a better idea because you can't deliver a very huge area of glue over the perforation site in such a big perforation. So this will be better in the larger perforation. Without this, it's easier to be for the smaller perforation.
So Dr. Liew, what are the common problems we encounter when we apply the glue? What are the advice you want to give to, medical officers or young surgeon or young ophthalmologists when they're applying the glue? Because the glue, as I know, it's very liquid. So it's when you are not careful, you'll turn into a disaster. Can you share with us your experience?
Yeah. The reason we put a glue there, first thing, you want to seal the perforation. So you have to make sure your glue stick very well on the surface. So first thing, you have to dry it completely, the perforation site, and usually they will kill continuous leaking of the aqueous fluid from the perforation site. So you try to dry up the area with the Spontac right before you put the glue on top of it. And then the second thing, and after you put the glue on top of the cornea, you have to remove your Spontac immediately because it will solidify very quickly after presence of the fluid on the cornea. And if you remove too slow, you may pull the glue together with your Spontac. So eventually it didn't glue you didn't do the glue successfully. And second thing, if you put too much glue on the this Spontac handle there, you deliver a very high and very fake glue on the cornea, and then eventually you want to put the contact lens on top of the glue. It become irregular surface and make the patient very discomfort.
Yes, correct. So I do have I encounter some of my medical officer when putting the glue and then unable to adjust the amount of glue applied to the cornea surface. So eventually the glue go everywhere towards the whole cornea. Some gone into the fornix, some gone into the lid margin, become very messy, and then it become a conical shape. So patient unable to fit the contact lens properly. Patient also unable to close the eye, feel very foreign body sensation. So these are the things that we medical officers and maybe young ophthalmologists can bear in mind. Just put enough of glue. Don't put too.
First you tap the Spontac on the drop of the glue, and then you tap again on the clean sheet again, the plastic sheet, to thin out the glue. So when you deliver to the eye, it will become very thin layer. Yeah.
Okay. Thank you, Dr. Liew. So to answer the one question is where can we get amniotic membrane in Malaysia? This question also is not fair to direct it to Dr. Kam, so I asked Dr. Liew again. So Dr. Liew, in your experience, you work in Sungai Buloh Hospital, and then currently you work in Hospital Queen Elizabeth Sabah. So what is your experience in the amniotic membrane services in Malaysia?
Actually, we didn't harvest the amniotic membrane by ourselves so far. We haven't tried that, but I hope that maybe in one day we can do that as well. Just need to prepare the get the protocol from Dr. Kam, and then we have to prepare the solution to do the washing and buffer solution for the washing of the amniotic membrane. Right now, we are quite lucky to have a USM, University Science of Malaysia. They actually have prepared the amniotic membrane in the glycerol solution. Basically, it's a wet AMT. So wet and amniotic membrane is better for us to work on the ocular surface problem, because the dry one, you can't really, for the dry amniotic membrane that available commercially, it's quite difficult for you to use on the Steven Johnson or chemical injury patient, because you need to suture it over the ocular surface. So we are quite lucky to have USM to provide us the amniotic membrane under glycerol. That one, I believe all the hospital around Malaysia is using that amniotic membrane. Yeah,
I see. I think only the Cornea subfacility, can order that the amniotic membrane.
No, actually, you just need to find the supplier. You can get the contact from me. Have no financial interest on that.
Okay.
We can help in that. Yeah.
If I have a question for Dr. Kam. Dr. Kam, for your experience, just now you mentioned regarding the amniotic membrane can dissolve over time. So what your experience, how long will it take for the amniotic membrane to dissolve?
It usually takes about 2 weeks.
About 2 weeks. After that, it will be thinned out, and then it will be. I see. But then what I noticed your case series is most of the patient with proper ICU care and proper systemic treatment, usually by 2 weeks to 3 weeks, they are quite symptomatically free. So the amniotic membrane basically is to prevent further sequelae from the Steven Johnson itself.
That's correct.
Yes.
Usually the first time when I saw these patients, they are in the ICU or in a very ill state. And the second time when I saw these patients, usually they are discharged to a general ward. So at a later stage. So, and then afterwards, I will see them in the clinics. So I usually do not counsel on the amniotic membrane. I usually do not perform amniotic membrane on the first day. I will usually just assess the condition first and then talk to them about this option. Many times the patients may not understand much about amniotic membrane at all. So they need some time to digest that information. And it's particularly scary when they know that this procedure is going to take away their vision for about 2 weeks. So as you can read from Dr. Sharma's paper, the initial visual acuity after putting on the amniotic membrane at 1 week is worse than before, worse than the medical group, because you are actually putting something to cover their eyes. So after a while, they know that their conditions are getting worse or their condition is not improving with just medical therapy alone, then it's about time for us to put the amniotic membrane onto the ocular surface. So even according to the literature, it's not something that we should or we must offer on the first day. We usually will just assess the patient on the first day, make sure that we get every defect or the involvement recorded, where the lid margin is stained or whether there's any defect in the palpebral conjunctiva, and then we can decide on the best management plan for each patient.
So Dr. Kam, do you perform the amniotic membrane transfer under local anesthesia, right?
Yes.
Not,
yes.
no need sterile condition.
No, around.
Sterile.
Yeah.
So one more, because some of our attendees also are master students and they are undergraduates. So I noticed the classification for the severity of the SJS in the ocular side is not only corneal epithelial defect is not the important, but the pseudomembrane and the lid margin involvement is very, very important. So can you elaborate that? Can you explain why is it important? Why is it become so important? We look at the lid margin and also the development of the pseudomembrane.
I think when there is a pseudomembrane, it indicates that the amount of inflammation of the ocular surface is very severe. And the reason why, if we do not treat the lid margin well, I think it's related to the long-term risk of developing a recessed or posteriorly migrated lid mucocutaneous junction. Sometimes if you look at Steven Johnson's patients who were not treated at all in the past, so for example, they had Steven Johnson like 20, 30 years ago, and then they came to you, if you flip the eyelids, you will see that the skin border actually migrated backwards posteriorly. And when these patients open and close their eyes, the keratinized surface at the lid margin will constantly rub on the corneal surface. So this will create punctate epithelial erosion or repeated microtrauma to the limbus. And in the long run, these patients may run into the risk of limbal stem cell deficiency. So we have such a kid from Shanghai who was 5 years old when he first came to us from Shanghai, and he could not open his both eyes because of very severe lid margin keratinization. So when we put him under very mild sedation, we flipped the eyelids and we saw that the lid margin was completely keratinized. So he actually had a surgery done in another private hospital in Hong Kong before he was transferred to us. And we decided to talk, we counseled the mother on the use of mucous membrane graft taken from the lips. So we eventually performed that operation and we transferred the lid mucosa to treat that keratinized lid margin. So the reason why you're asking, eventually the patient, the child could open his eyes and go back to school, but he still required very intensive artificial tears treatment. So the reason why you're asking why is it important, I think it's because we don't want to prevent the damage done to the lid margin so as to prevent the chronic sequelae.
Yes, correct. This answered my question. I think it enlightened the others as well. So one final question to Dr. Kam. Dr. Kam, which side of the amniotic membrane should be put on the corneal surface, and does it make a difference?
Well, it is a very controversial topic, and it's been a lot of debate on whether you should use the basement membrane side or the stroma side.
Yes.
For myself, I've been using the stroma side all along.
I see. Any special reason for that?
I haven't really tried putting the basement membrane side down in all these cases. I do not have a particular strong reason. This is where what I learned from my senior as well.
Yes.
And if you really want to look at the literature, and they said if you put the basement membrane down, you are allowing the epithelial cells to grow under, so it works like a bandage contact lens. Whereas if you put the stroma side down, you let the epithelium to grow across, so that you incorporate the amniotic membrane into the cornea itself. So, for example, in another ocular surface procedure called simple limbo epithelial transplant, we usually put the stroma down. So on subsequent ASOCT, you can see that as the new epithelium heals, you can see a very thin layer of amniotic membrane being incorporated into the new cornea after the surgery. But clinically, I haven't really tried enough to tell you the actual difference. So how about you? Do you use specific orientation when you put amniotic membrane onto someone's cornea?
Dr. Liew, yeah.
So far, I still all stroma down, like because I learned from Kam.
Okay, I think it answered the question to our attendees as well. So
I saw another patient asking there. He asking, what do I use for the disc to covering the perforated cornea? I think we all thought in the way that we just simply cut any plastic sheet and measure the size and use the skin punch to punch the size of the disc, and then use the ointment CMC to carry the disc with the glue and then tap it on the cornea. There is a pretty standard procedure that we was taught to be during our master training, you know.
Yeah.
So that's how we do it right now. But now for small perforation, I wouldn't use this anymore nowadays.
Yeah, I noticed in your presentation, so you put the glue in layers. When you put in the glues in layers, I mean, you're able to fill up the gap, fill up the hole in a sequential manner. Eventually, you look at your picture, the perforation have able to level up, which is quite good. This is we achieve our aim. Yeah.
There's some patient also, even though you use the disc, there is a video actually shown by uploaded by Dr. Rajesh Frogra in YouTube. You actually see him. He used the disc to deliver the glue over the cornea, and then eventually, before he applied the BCL, he will purposely remove the disc as well, because the disc wouldn't stick well to the glue. So plastic to plastic is difficult to stick. Yeah.
I see.
So only to tissue, so the glue will stay there long.
Understood. Thank you, Dr. Liew and Dr. Kam, for such an impressive and comprehensive presentation. I believe in future we have any other cornea talk, we would like to invite Dr. Kam as well. Right. Thank you everyone. Thank you all the panels and all the invited speakers and attendees for staying with us from 3 to 4 o'clock. Such a wonderful talk. We will have on and off. We will have in future. We will have further talk like this. And with that, I end this webinar. Thank you again. We will keep in touch with Dr. Kam and Dr. Liew. Thank you.
Thank you.
Okay, see you everyone. Bye.
Bye.